All right, besties. Y'all know what time it is. It's time to talk about feet. You guys know I like feet in like the most long, creepy way. But let's talk about lateral ankle sprains. So this is probably one of the most common ankle injuries you will see. It's also very popular on the exam. So let's kind of talk about the anatomy associated with it. I know it's a little bit of a blurry picture, but it's going to be the ligaments of the lateral ankle. Makes sense. The main ones that are affected in the order of importance and potential tearing is the ATFL, so anterior talofibular ligament, not tibiofibular. That's going to be up higher. That's like a high ankle sprain. Talofibular ligament. So it's called talofibular ligament because talo for the talus or talus or however we want to say it. The ligament will attach from the anterior part of the distal fibula, which is going to be the lateral malleolus, to the anterior part of the talus. So therefore, makes sense why that's what that's called. So very important, and I'm emphasizing this because they will put tibiofibular. I literally just took a practice exam today, and they put tibiofibular to try to throw you off. I'm telling you, they will do it. So just be aware. Talofibular. So your ATFL is most commonly torn. Then your next most commonly torn would be your calcaneofibular ligament. So it goes from the calcaneus to the fibula. So that little pointy part on the part of the most distal part of the lateral malleolus, that is where we're going to see this ligament live. Second most commonly torn, and then the posterior talofibular ligament. Again, same kind of thing, talofibular. This one is not torn as often. Like if this one tears for like lack of a better word, you really fucked up your ankle. Like if this one's torn of your posterior talofibular ligament, the other ones are probably all torn, and you probably have to have like a complete lateral ankle reconstruction. So yeah, it's that one's really bad. That's like a severe traumatic injury. The only person I've ever seen with that, their foot was like completely crushed. So yeah, like they were on the verge of like maybe they need to get it amputated. That's how bad it was. Um, Everybody else mostly going to see that ATFL tear, that calcaneofibular ligament. Sometimes likes to hang out and go along with that anterior talofibular ligament tear. But these are the ligaments that will prevent inversion of the ankle. So it makes sense. They're on the outside. If you invert your foot, you're going to stretch these muscles here, or these ligaments here, sorry. You're also going to stretch the muscles there on that side too, but you're going to stretch all of the lateral structures when you invert the foot. If you evert the foot, you stress the medial structures, which is your deltoid ligament, which takes a lot to tear that thing. But these ones on the outside, they're little flimsy little suckers. They tend to tear very easily. If you tear them once, you can tear them again. But just wanting to emphasize the anatomy because that's one of the things we'll talk about in question. So again, we have our inversion sprain here. So oopsie, I stepped in a hole and I rolled my ankle. I'm telling you, in the spring, the bunny holes, those are the worst. So be aware. The amount of patients I had in the spring with lateral ankle sprains because they stepped in bunny holes wrong was astronomical. So be aware of that. So inversion and plantar flexion injury is going to be the like most common mechanism of injury specifically for tearing your anterior talofibular ligament, your ATFL. If you have any sort of inversion though, those other structures, especially your CFL, are definitely at risk. So yeah, rolling your ankle inwards is the mechanism of injury. This will happen to high impact athletes with jumping. That's like a common one you'll see, or just regular people walking in their yard and stepping in a freaking bunny hole. So once you've torn it once, you're prone to tearing it again. So these structures, again, they're very flimsy. They're spoiled. If they get messed up once, they're going to be dramatic and cause problems again. So again, what's going to happen with these patients is it can also be bad for those who have impaired proprioception. So thinking of someone who's got diabetes or something like that with that peripheral neuropathy, if they can't really feel where their foot is, they might not know they're stepping down like off of a step, like going down the steps. They might not realize that their foot is turned inwards and then they end up tearing it by stepping on it weird. Definitely have had people tear this by stepping down off a step weird. Again, they resist inversion. So if you invert too far, you can break these. So therefore, look, we're inverting really far. These ligaments get stretched. They can only get stretched so far before they go and pop off. So definitely not good. What does it look like? Makes sense you've torn something, so there's going to be tenderness and swelling there. You'll see If you guys have seen this before, it looks like there's like a golf ball on the side of the person's ankle. It's pretty bad if they really mess it up. So that swelling and edema is huge. You might also see bruising, which the fancy name for bruising is ecchymosis. So you'll see bruising there due to the tearing and the blood trying to enter the area to try to help out. Your ankle will be unstable, so they won't be able to stand on one foot. One, due to pain, so that decreased weight bearing tolerance, they'll have that antalgic gait, and two, due to ankle instability. They're going to have limited range of motion, which is probably going to be, like, I'm not saying probably, it will be due to the fact that they're swelling. Because you would think, oh, we tore a ligament, it's all loosey-goosey now, there should be more range of motion. No, it's swollen, so you're going to have what's called a boggy, and yes, like a bog, the bogs in Great Britain. Yeah, so you have a boggy end feel because of all the swelling and edema. So you'll have limited range motion with that. Again, one of the special tests performed is an anterior drawer test of the ankle. There is an anterior drawer test of the knee, which will be for your anterior cruciate ligament. This for your anterior talofibular ligament. Yay! So again, you basically cup the heel and pull it up pull it into like front, like anteriorly. And so what ends up happening is if that's positive, you'll see like gapping and it'll be like, ooh, it's kind of wild when you see it. And then a positive talar tilt test is going to be for the CFL and the ATFL. So basically you have the foot and you will basically keep it in like neutral and inverted. That's gonna cause some, again, they'll have pain, swelling, and gapping. So those are the two special tests. So if you see those, you can pretty much say, ah, we're in a lateral ligament sprain land. So how are we treating it? So again, we have our different phases that we progress through with any sort of condition. So the acute phase, we're going to do gentle range of motion, some modalities to decrease pain, we're decreasing swelling, we're improving the patient's weight-bearing tolerance, like pulsed ultrasound, and I put ew because like nobody cares about ultrasound anymore. And grade 1 and 2 mobilizations. So again, you might be like, but Brie, if something's loosey-goosey, why are we mobilizing? Remember, grade 1 and 2 can help with decreasing pain. So those can be helpful as well. So and like E-stim, oops, sorry. Ice and E-stim will definitely be like the number one things you're going to use with this patient for modality land. Subacute phase, that's where we work on getting strength back. So a lot of people like to do like ankle four-ways or something like that. So ankle strength, like BAPS board for range of motion, stuff like that. So getting our basics back of range of motion and strength. As they get like through that phase and like now we have some ankle strength and we can actually stand on one foot, then we're going to work on our balance proprioception, have them walking over uneven surfaces, balancing on foam, normalize their gait mechanics. Again, you'll be working on gait mechanics through all of this once they can weight bear, but then we'll go back to, activity and sport. So we'll progress through those stages, but definitely balance stuff is important for this patient because that's what the ligaments do. They help maintain stability while we balance. So again, inversion and plantar flexion sprains. So that's our mechanism of injury. Swelling on the lateral ankle, pretty big indicator, especially if it's like right below the lateral malleolus. So right below the lateral malleolus, we'll see that. Positive talar tilt test or anterior drawer test, you pretty much know we're in lateral ligament sprain land. Instability, huge one. If they've had it before, they could have it again. So previous history, definitely a big one. And then tenderness below that lateral malleolus is another big key word there. Sample question. A physical therapist assistant is treating a patient who is in the subacute phase of recovery following a grade 2 lateral ankle sprain. The patient still presents with severe pain with single leg weight bearing and some pain with active and passive inversion. Which of the following interventions would be least appropriate at this stage? So one would be seated ankle range of motion on a wobble, BAPS board. Two, ankle four-way strengthening with a TheraBand. Three, single leg stance ball toss. Or four, mini squat. So I'm going to give you guys a minute to think about that. By minutes, probably like 15 seconds. All right, guys, so the answer is single leg stance with a ball toss. So let's kind of break this down of why this is the answer. It's asking about which is least appropriate at this point. So if they're in that subacute phase, they're still having some pain with active and passive range of motion, well, specifically inversion, which makes sense. So due to that seated ankle wobble board, that's probably going to be good for them. Still working on range of motion there, because that's one of the things that they're struggling with range of motion. And they have severe pain with single leg weight bearing. Says that it doesn't say anything about double leg or if they're seated. Like this probably isn't going to put a lot of pressure. So I would say during this phase, that's probably appropriate. Ankle four-way strengthening of the TheraBand, pretty much the staple at this phase. Like this is what most people are doing in this phase. The single leg stance ball toss, because they have that severe pain with single leg weight bearing, I don't think we would make it more complicated at this point by having them do a ball toss. If they can't even like stand on one leg without severe pain, we're not going to progress them to this. If anything, we're going to be regressing to maybe we're going to work on some weight shifting to kind of get more, comfortable with that pressure on that foot. Mini squats is going to be double leg and it's going to be strengthening, which is totally appropriate at this phase. I believe they'd be able to tolerate, but if this is putting the patient in severe pain, like that's a big thing. If it's severe pain, we're pushing too far. I would say that that's too much of a progression. And at this point, we might need to scale it back just a little bit because what we really want to make sure we're doing is that we decrease the pain first before we try to ramp everything up. Think about it, if you're in like a lot of pain and I'm telling you like let's do like repetitive like sprints, you're gonna be like, can we not do that? But then if I'm telling you like, hey, like if like let's say your foot's in pain, if I'm telling you let's do like repetitive sprints, you're like, okay, like that's really high impact and that's like kind of painful right now. But then if I tell you, hey, let's do some hip strengthening and maybe just some like stability exercises like on the table or like some with, without weight bearing, but we're still working on strengthening. That's probably more appropriate. Like you want to scale things back. People, you don't want to push too hard forward because if you're pushing somebody who's already in pain, we're increasing that inflammatory process and just starting it over and over again. So, yeah, basically with this, I want you to notice like what would be like seeing that that's too far of a progression. They're not ready for that yet. Maybe once they're in that chronic phase and the pain has decreased, then we're going to move to this single leg stance ball toss. All right, guys, hopefully that was helpful, and I'll see y'all in the next one. Take care.